All right, cool. Yeah. Perfect. Okay. So again, thank you guys for being here. I have to give a presentation, or I get to give this presentation for my health promotion and wellness class, part of the UAMS PT curriculum. Can you guys hear me okay, first of all? Like,
I can hear you. Yes.
cool.
You're good.
Um, so yeah, I chose health insurance literacy because I thought it was an important topic, and I learned through the research that I did for this that it is very important and that it has some real world effects that we might not realize. So I'm timing myself. So if we get close to 40 minutes, I'll stop, but it hasn't taken me that long when I practice this, so we should be good to go, but I don't want to waste any time. But again, thank you guys for being here. I really appreciate it. Um, so health insurance literacy, it confuses Americans generally. We're going to see that it confuses providers, the people that sell the health insurance to us. It's not well understood by a lot of folks. And this confusion has consequences. So you can see here that 60% of insured Americans put off making appointments and 50% put off filling a prescription because they don't know what is covered by their insurance and they don't want to risk it. So that's not excellent. So what is health insurance literacy? So the definition is right here. It's a person's ability to seek, obtain, and understand health insurance plans. And once enrolled, use their insurance to maximize the benefits they get from those plans. But again, 1 in 4 Americans avoid going to the doctor because they do not know what is and isn't covered by their health insurance. So in addition to that, decreased understanding of Medicare leads to more emergency room visits, and that leads to an increased $32 billion a year that we spend on healthcare that we wouldn't have to otherwise spend if people could utilize Medicare the way it was intended. In addition to that, health insurance literacy has been shown to decrease during times of economic difficulties. That paper I reference here is talking about economic difficulties for cancer patients due to that diagnosis, but I think that thought process follows through for like whatever the cause of economic hardships are. When you are like struggling to make ends meet, you don't really have time to go down the rabbit hole of health insurance and try to teach yourself all that you need to know to navigate this as well as you possibly could. It's never ending. So, um, yeah, it's also just unfortunately the case that providers don't really get taught this in school. Um, I found an article that was arguing that this should be taught in medical school curriculum, implying that it's not currently taught. And I can tell you from my personal experience, and I think from UAMS's PT program, and I think there are some people here from the UCA's PT program, we have not been taught health insurance literacy or basics, anything like that, to the degree that I gathered information from this talk. Um, and I hinted at this earlier. So the people that sell us and are supposed to know the most about health insurance, health information intermediaries, when they were given objective tests to measure their understanding of health insurance, they also scored them. So the people that are selling us and pushing health insurance plans for us to purchase, they also are confused by um, this process and this terminology. So none of us really seem to know what's going on. And until we develop a better system for delivering healthcare, like other countries have been able to do, all we can do as providers is try to educate ourselves so we can educate patients, and as patients educate ourselves so we can look out for each other and try to teach others. You know, who does this issue affect? Health insurance literacy is usually lowest among those who are poorest, minority populations, those who speak English as a second language, those with education levels, and those who are younger, because the younger you are, the less likely you've had an opportunity to experience the healthcare system as it is and like learn this as you go through it. And this kind of helps to explain why the majority of Americans feel failed by the current healthcare system. So this is just Arkansas State website. The picture on the left is it's like the county breakdown of overall health literacy. So health insurance literacy is a component of overall health literacy, but I would argue it's a large component. Regardless of that, you can see that the counties in dark green have the lowest health literacy in the state, and the polka dot green counties have the next lowest. But even the counties that are like best off or better off, they still have 27 to 34% of people that are health illiterate. So we can improve as a state, and obviously like just as a country overall. Um, the right picture here is the cost that this health illiteracy um, accumulates to per county per year. So again, the dark green counties are the ones that spend the most, $1,800 to $2,100 due to health illiteracy, and the white counties spend the least. But either way, this is obviously an issue here in Arkansas and nationwide, and so that's kind of why I picked this topic. So we know already from a 2017 survey that only 9% of people are able to answer 4 questions on basic health insurance terminology. And a PBS poll from last year found that 8 in 10 people here did not think they would be able to access healthcare if they needed it in the most efficient way. Um, it's also been shown that people that have the lowest objective understanding of health insurance tend to overstate their ability to understand this process. However, through researching for this presentation, I found a paper looking at Arkansans like level of trust and like where they felt they could get the most accurate information during the COVID pandemic. And I found that in this paper that I referenced, 91% of Arkansans felt that they could trust information that they received from their primary care physician. And to me, just kind of going back to this point, that means that as providers, we need to talk to our patients about this because they'll trust what we're telling them, and I think they would act on it because they believe providers, and we're the best. They're the best equipped to have this conversation with patients. So, with all that being said, I'm just going to take us through some common health insurance terminology. I'm going to talk about some private plan types. I'm going to talk about Medicare and Medicaid, and then I'm going to wrap up with Medicare Advantage plans. So, what is health insurance? It's an agreement that your insurer will pay for some or all of your healthcare costs in exchange for a monthly premium. You can think of that monthly premium as like the equivalent to a gym membership. Whether or not you go to the gym, you have to pay a monthly amount to have access to the gym. And in the same way as you pay for a gym membership, you get benefits with that. When you pay your monthly premium, you get benefits for paying that premium. But those benefits depend on the plan, as does your premium. So while your premium is similar to a gym membership, your deductible is the amount of money that you have to pay by yourself before your health insurance begins to kick in and cover any percentage or any amount of healthcare costs. Deductibles usually operate on the calendar year, so they start on January 1st and they go through December 31st. However, that can be different depending on state and depending on who your employer is and what insurance you have through them. Generally, though, your deductible and premium are inversely related, meaning that if you have a lower premium, your deductible is going to be higher. And if you have a higher premium, your deductible is going to be lower. You can see from this picture that a lower premium is a good option for people who don't plan to use healthcare services, because that's how that works, right? You always plan to use healthcare services. And if you have a higher premium, that's better for people that do plan to go to the doctor more often, because that means your deductible is lower, you're going to need it faster, and your health insurance will begin paying sooner than it otherwise would have. So, thrown in some knowledge check questions just to make sure I can give you guys some like real world examples if you don't know this stuff, because I didn't when I started research. So Helen's a 46-year-old mother of 3 children. Her husband's health insurance has a $1,000 deductible for the family each plan year. Helen's 8-year-old son requires a medical procedure that will cost $1,500. The family already paid $750 toward the deductible this year. Assuming the service is covered by the health insurance plan and there are no copays or coinsurance, what will Helen pay for her son's medical procedure? So they got to get to 1,000. They paid 750. So sorry that there's math in this, but
250.
Yep. So, okay. Copays and co-insurance. I just talked about this. So copays or co-payments, another way for you to split the cost of insurance with your insurance company. So that's a set amount of money per procedure that doesn't change regardless of whether you met your deductible or not. Coinsurance, on the other hand, similar to copays, and coinsurance only begins to kick in once you've met your deductible. And unlike copays, coinsurance is usually a percentage of a procedure rather than a set dollar amount. Sometimes we'll see insurance companies offer things as being 100% coinsurance. That is a trick. That means that you're about to pay 100% of the cost for whatever that procedure is. That does not mean they're covering 100% of it. That means you are responsible for the entirety of that procedure. So beware of that. Don't fall for it. Okay, so copays do not count towards your deductible, but copays and your deductible count towards what's called your out-of-pocket maximum. And your out-of-pocket maximum is the maximum amount of money that you would have to pay in a calendar year for healthcare services before your insurance company, from that point on, cover any additional costs of healthcare. And the only time that your copay or deductible would not count towards this out-of-pocket maximum is if you visited a provider who is out of network. So leads me to our second question. Mrs. Simmons' insurance plan has a $3,000 out-of-pocket maximum, a 60-40 coinsurance plan, meaning that she has to pay 40% coinsurance with a $250 deductible. She has a procedure that costs $8,000. She has not met her deductible to any degree for this year. How much is she going to be responsible for paying? So off the bat, she's got to meet that deductible. Then you got to take 40% of 8,000, add that up. It's more than that total is going to be more than $3,000. So since her out-of-pocket maximum is $3,000, that's what she has to pay. After that amount, her insurance is going to cover the rest of the cost for that procedure and any additional healthcare services for the year. So this kind of leads me into what is in network and out of network. All insurance companies have an agreement with providers that the providers will accept the insurance you're buying and that your insurance will pay those providers a certain reimbursement rate. That's literally what in-network means. It's just like they have a contractual agreement with each other. So therefore, out of network means that you're seeing providers that have no sort of contractual relationship with your insurance company, which means that it's going to cost you more because your insurance company is not going to pay those providers. There's no relationship there. So you'll have to pay more for out of network providers. That's the big takeaway. This is just a visual example of that. So the circle on the left picture is your network. Those providers are in the circle, so they're in network, so $1. The out of network providers are outside of the circle, so $4. So just that's the big takeaway. Out of network costs you more money than in network. On the right is an example of how the total you owe can be different depending on an in-network surgeon versus an out-of-network surgeon. You see that for the in-network surgeon, you'd only pay $600. For the out-of-network surgeon, you'd pay $8,500. And if you want to look at this in detail, I can email the slides to you once we're done. But there are some dangers with this in-network and out-of-network definitions because you're responsible for making sure providers in-network. And that applies to doctors that you don't even necessarily have a choice over selecting, such as like an anesthesiologist for a surgery. It also is the case for life-threatening emergencies. And it's an unfortunate truth that 60% of all ground ambulance rides in America are out of network. In 2022, there was a bill that was passed that attempts to reduce the amount of money that patients are surprised with after seeing someone who was out of network that they did not know was out of network in those situations. But for whatever reason, ground ambulance rides were left out of this bill. I think I was reading, it said that it was too complicated. I'm not sure how that came to be, but the median cost of an ambulance, a ground out of network ambulance ride is currently $450 nationally. There are some states that offer protections against these surprise ground ambulance bills, but Arkansas is not one of them. Okay, so this kind of leads me into the most common insurance types and plans. There are more than these four, but I just chose these four because I think they're common. These four are preferred provider organization or a PPO, health maintenance organization, an HMO, an exclusive provider organization, EPO, or a point of service, POS. I'm going to cover those in greater detail here in a couple slides. Typically, though, each of these plans are found at each level of private insurance. And those levels for most insurance companies generally go bronze, silver, platinum. So there's a PPO, HMO, EPO, POS bronze plan, a PPO, HMO, EPO, POS silver plan, so on. And as you progress from each level, the monthly premium you pay increases. But so the benefits that you get for that. So I put the averages in 2023 for a silver plan and gold plans there. And then I also was able to find the average um, percentage that your employer would pay for these insurance plans in 2021. That was the most recent one I could find. So they would pay 83% for a self-insurance plan and 73% for a family plan. So basically, if you were just getting insurance for yourself, the silver plan in 2021, your employer would pay 83% of 560, and you'd have to pay the remaining amount each month, and then that's how you would get your insurance. Jan is a 40-year-old woman who wants to enroll in a silver PPO plan through her work. The monthly premium for the silver PPO plan for someone her age in 2023 is $540 a month. Her employer will cover 60% of the cost of this premium. How much should Jan expect to pay each year for this plan? Um, this one's a bit longer. We'll just kind of walk us through it. All right, that there's math involved in this. So we take 60% of 540, subtract that from 540, multiply that by 12 because it's asking for the yearly amount. That gives us $2,592. But that's just another example of how that would work through your employer. Um, Again, each of these plans are present at every level, bronze, silver, gold, platinum, but they still remain different in key ways. And those key ways include whether or not you need a primary care physician, whether or not you need a referral from that primary care physician, and how large your in-network provider pool is. It goes without saying this, but the plans that make your life the easiest, so the ones that allow you to see specialists without a referral and have the largest in-network pool, that's going to cost you the most money. So more specifically, the plans that require you to have a primary care physician are the HMO and POS. The plans that require a referral are from the primary care physician, therefore are also the HMO and POS. But this is the plans that offer coverage for out-of-network providers to some degree are the PPO and POS. That kind of helps explain why the PPO is the most common plan. You don't need a referral. You don't have to have a primary care physician to see specialists, and they do offer some out-of-network coverage. So therefore, that's why that one's obviously 49% most common, but that also explains why it costs the most. Okay, so if you had like an HMO and you wanted to switch to a PPO, or do you just wanted to change like maybe levels, you could do that during open enrollment, which is a yearly opportunity that you get to change your insurance plan. Typically, it's November 1st through January 15th. But again, that can vary by state and employer again. Outside of open enrollment, though, you can only switch insurance plans if you've had a qualifying life event or a QLE. Depending on that event, you could do it either 60 days before or after the event. And I'm saying before or after because sometimes these things are going to happen. So I provided 4 examples here, such as moving to a different zip code, a death in the family, having or adopting a child, or becoming a U.S. citizen. So you typically don't know if there's going to be a death in the family. If you start looking for insurance and there's a death in the family, that's pretty suspicious. Don't do that. Those are just a couple examples, though, of events. If you want a more complete list, you can go to that website there and see all of the different qualifying life events that there are. So, okay, another question. So, Juan, a 50-year-old construction supervisor, is very particular about the doctors he visits for his back problems. He asks you which plans will cover out-of-network care and pay for at least a portion of the healthcare costs. Which of the following types of health insurance plans should you tell him would give him access to those features? Select the 2 correct answers. So if anybody take a guess.
A and B.
Yep. Those are the ones. Yep. They offer out-of-network coverage. Maybe not completely, but they do offer some. So, okay. Since we just covered the private options, I'm now going to talk about Medicare and Medicaid. They sound similar, but they are different. So both are federal programs with the goal of increasing health insurance coverage. Medicaid is typically for those who are low income. It's administered by each state, even though it's like a federal program. So because it's administered by each state can do it differently. They have its own rules for qualifying, and they also have their own different like benefits. Each state has to have a mandatory list of benefits that all the Medicaid programs offer, but they can also offer optional benefits, and those are the ones that depend on the state. So the optional ones are not mandated to offer, but obviously the ones they are. Medicare, on the other hand, is traditionally for older adults, usually over age 65. And unlike Medicaid, Medicare is administered federally, which means its benefits are consistent state to state. So you can go anywhere in the country and the benefits from Medicare are going to be the same. You can also qualify for Medicare earlier if you have end-stage renal disease, if you have Lou Gehrig's disease, or if you have a diagnosed disability. So it's not exclusively for older adults, but it is the majority of people that are enrolled in Medicare. So I just want to take a second and show you like the picture on the left, those are the minimum benefits that every state has to offer. And then the selected optional benefits are the ones that states can either choose to offer people in Medicaid programs or not. And so during the pandemic, obviously people that qualified for Medicaid increased because of, people lost their jobs, people needed insurance. And during the pandemic, states were prohibited from kicking people off of Medicaid because they were receiving like increased federal funds. So that was like an agreement all the states had. During the emergency pandemic, you couldn't kick people off Medicaid. We're going to give you extra money. That was just the deal. But in April, COVID-19 emergency was declared over. And since that time, roughly 427,000 people in Arkansas have been kicked off Medicaid. And that includes 148,000 children and 25,000 newborns. That's just kind of like the state of Medicaid in Arkansas. So this leads me to Medicare. Medicare has four parts: A, B, C, and D. Each part of Medicare covers different aspects of overall healthcare, and each part is paid for in different ways. So Part A is inpatient hospital stay coverage, and it's mostly funded through payroll taxes and Social Security benefit taxes. So that's the one that people think of when they think of Medicare. Usually, that's the one that gets taken out of your paycheck every 2 weeks or however often you get paid. And that's why you don't pay a monthly premium for Part A when you qualify for it. So if you or your spouse works for 10 years and pays these payroll taxes for 10 years, you guys are both good. You qualify for Part A Medicare. Part B Medicare is outpatient or medical coverage, and it's mostly funded through federal income taxes, but the remaining 25% is covered through monthly premiums. These premiums are automatically taken out of your Social Security payments if you are getting those. So the premiums have a base rate of, I believe in 2023 is 134.70, and that's what everybody has to pay unless you make over a certain amount of money. I believe as like an individual is like $97,000. And if you make more than that, you pay like slightly extra. So yeah, usually though, if you're getting Social Security payments, you don't even see that money. You don't have to pay it. It just gets taken out of your Social Security benefits. Part C is what is commonly referred to as a Medicare Advantage plan, and I'm going to go over that in a lot more detail here in a second. Part D is prescription drug coverage, and it's funded through general revenue, monthly premiums, and payments from the state for those who qualify for both Medicare and Medicaid. So that has the most diverse funding options. Like that's the one that's funded by the most different things out of all the different parts of Medicare. Okay, so in addition to these four parts of Medicare, it's common for those enrolled in traditional Medicare, which is Medicare A and B, to be insured by a Medicare supplement plan, which is also known as Medigap. That's because traditional Medicare, again, parts A and B, only cover 80% of the costs of healthcare, and the Medigap plans will usually cover the remaining 20% in the form of deductibles, copays, and coinsurances. So that does mean that you would have two premiums a month, but that also means that it is overall cheaper because when you go to the doctor or wherever, you wouldn't have to pay anything else because these two plans would cover it. So this is just kind of what I went over. So the parts of Medicare on the left, we have A, B, C, and D. A is hospital coverage, no premium. B is medical coverage, monthly premium. C is a Medicare Advantage plan. And Part D is prescription drug coverage. Medigap plans are on the right. It's a filler plan for the 20% of healthcare costs that traditional Medicare doesn't cover. Okay, so what part of Medicare is funded mostly by payroll taxes and does not require you to have a monthly premium for benefits once you have enrolled?
A.
Yep. So these are the options we have for receiving Medicare benefits in the United States currently. On the left is original Medicare, Part A and B, with a Medigap plan to cover the 50%, and then Part D is an optional enrollment too. On the right, I have the percentage of those that are opting to, instead of enroll in traditional Medicare, sign up for what is Part C, the Medicare Advantage plans. And you can see in 2022, that's nearly half of all the people that are eligible for Medicare. They're choosing to enroll in a Medicare Advantage plan. So what are these? These started off in the 60s as a way for employer-based insurance to continue for you to see the same physicians after you retire from your job. So if you had a relationship with a doctor that you liked through your employer insurance, these were a way for you to continue seeing that same doctor after you had retired. Since then, though, they've kind of morphed and there's been history and the names have changed, and they are currently offered by private health insurances that have been approved by the federal government as an alternative to traditional Medicare. So because they're private insurances offering these plans, they're almost exclusively HMO or PPO plans. And again, this is possible because this is not through the federal government. They are private companies that have negotiated with Medicare to offer these plans. And as of 2023, over half of those who are eligible for traditional Medicare have chosen to instead purchase a Medicare Advantage plan. Okay, so this is important. So traditional Medicare is a fee for service. So that means that the Centers for Medicare and Medicaid Services, or CMS, sets the reimbursement rate for that year for all services. As long as a procedure is a covered service, which most of them are, the doctors, all they have to do is bill Medicare, and Medicare will pay the doctors directly the reimbursement rate that they've agreed on for that year for a procedure. With Medicare Advantage plans, CMS gives a fixed amount per patient per month, which I believe was like $1,100-ish, to a private health insurance company, Blue Cross Blue Shield, Aetna, United Health, Cigna, whichever one, doesn't matter. But with Medicare Advantage plans, Medicare does not pay the doctors directly. The private companies receive the payment from CMS, and then they negotiate a price with doctors, hospitals, whoever, to give them a percentage of what CMS has given them. And since the goal of these companies is making as much money as they can, they will often not pay doctors the same amount that traditional Medicare would have, and they pocket the difference. So that leaves you having to pay the difference, or as we'll see here in a second, outright just be denied care. And in addition to these differences in reimbursement, the Medicare Advantage plans are regional. So if you have to move for whatever reason and you're enrolled in one of these plans, it might not offer you any insurance at your new house, at your new location, at your new residence. You might just be kind of out of luck. And then the other big difference is that with the Medicare Advantage plans, you have to get prior authorization from the insurance company that's offering you that plan before you can see a specialist provider. With traditional Medicare, you can just go to the doctor. You don't have to get prior authorization because, again, the doctor just bills Medicare and then Medicare pays the doctors directly or the hospitals. There's no middleman. But with the Medicare Advantage plans, the middleman is the insurance company. So this is just kind of, again, summarizing what I just said. Referrals are not required for original Medicare, but they are required for the Medicare Advantage plans. The Medicare Advantage plans also replace original traditional Medicare A and B. So kind of moving forward, going off of that, these Medicare Advantage plans are being criticized right now for continuing to deny medically necessary care that would have been approved had the patients been enrolled in traditional Medicare. This is the case despite these Medicare Advantage plans being required to offer the same benefits as traditional Medicare. So what happens is these Medicare Advantage plans, their in-network providers are so small, um, and that's just not really known to people that enroll and buy these plans until it's too late, and then they get denied because they need the prior authorization, and then they have to fight the appeal, and then they're just kind of stuck for a while. There was also a report in 2018 that found 1 in 5 payment requests were wrongly denied by these Medicare Advantage companies. So that translates to 1.5 million people who were denied coverage to medically necessary care, meaning it wasn't like an elective surgery or an elective procedure. They needed this done, and they got denied when they would have been approved had these seniors been enrolled in traditional Medicare. And due to this, a lot of hospitals are dropping patients that have Medicare Advantage plans. It's becoming more common. In fact, United Health was recently caught using an artificial intelligence algorithm called NH Protect to prematurely and in bad faith discontinue payment to its elderly beneficiaries, causing them medical or financial hardships. So when you get denied, if you are on a Medicare Advantage plan, a person may not have even read your claim. Like a computer gets it, they use an algorithm, and it's not based on like your health outcomes. It's based on how can we make as much money as possible. They deny you, you have to appeal it. And while you're doing all this, whatever's going on with your body is not on pause. Like if you need like a cancer treatment and you have a Medicare Advantage plan and you get denied and you have to appeal, that cancer is still spreading, it's still dividing, it's still happening. So not awesome stuff. In addition to all this, these companies usually maximize their profits by systematically upbilling, which means that they tell Medicare that patients are more sick than they really are. These companies have also been caught bribing doctors with like vacations, fancy champagne, to entice them to add more diagnoses to patient charts. And these practices have led to a $20.5 billion amount of excess payments from CMS to these private companies. And as a reminder, CMS, Medicare funded through our payroll taxes and federal income taxes. So we're funding CMS and they're taking CMS funding and making that their private profit. It's also been shown that these companies have lobbied against congressional oversight that would stop these practices. So we're paying people off so they can continue doing this. So this picture on the left is highlighting how the Medigap, which is with original traditional Medicare, and Medicare Advantage are different. The biggest things are with Medigap, you have the freedom to choose doctors and you don't need referrals. With Medicare Advantage plans, you will likely be restricted. You would need referrals for specialists, and you would probably be denied and have to appeal to see a specialist. And I didn't know this until a few days ago, but with traditional Medicare, you can enroll 3 months before you turn 65 and 3 months after you turn 65. And during that 6-month enrollment period, health insurance companies that are selling you Medigap are legally obligated to sell you Medigap at the best coverage rate available. They legally cannot deny you coverage. After that 6 months, those insurance companies are then legally allowed to deny you Medigap coverage, or they can charge you a premium that is like astronomical and unaffordable based on your current health conditions. And usually people that are old enough to qualify for Medicare are going to have some sort of pre-existing condition. So yeah, there are only 4 states in the country that have a law that mandate insurance companies to continue to sell people Medigap plans at the best available rate, even if they miss this 6-month window. And those 4 are Connecticut, Maine, Massachusetts, and New York. So basically, if you miss this 6-month window to enroll in a Medigap plan, whether you're in traditional Medicare or a Medicare Advantage plan, you will not be able to receive the same quality of plan later in life. Unfortunately, you also cannot be added to your partner's Medigap plan. You have to, for whatever reason, buy your own Medigap plan individually. It's a racket. However, if you are a federal employee, you can retire with health insurance that offers similar coverage to Medigap policies, and your spouse can then be added to them. So this is just good information to know. So last question, should you sign up for a Medicare Advantage plan or let anyone in your family sign up for one? Please don't. I think generally they sound great. There's a lot of money that gets spent into marketing them, but when it comes time to pay for a procedure that is medically necessary, they won't hesitate to deny you. Also, I'm just going to shamelessly plug this kind of, if you're interested in learning more about Medicare Advantage plans, I liked this article quite a bit. Again, if you want me to send you the slides, I'm more than willing to do that. But you can listen to this, and I think it paints a pretty good picture of what's going on with those plans and how they operate. So just to wrap up, this stuff is complicated. I I feel like I could continue researching this forever, but I don't want to. I'm tired. I hope I'm leaving you guys with like a lot of questions. I have a handout that I'm going to email you should you want it, with additional resources on it. And again, I have the citations in this PowerPoint, and if you want those, I can send it to you as well. I do want to say thank you again. I know this content is not the most exciting. I appreciate you guys being willing to listen to me talk about this. I hope you understand that health insurance literacy does have real world effects and it influences health outcomes. And I hope that you're motivated to continue learning about this. If you have any resources for me, I would love them. Send them my way. Also, if you're listening to this and you're going to be a provider, please consider talking to your patients about this. It could change their lives. I don't think I have anything else. So unless anybody has any questions, that's it. So assuming not. Cool. Well, thank you guys for being here. I appreciate it. Yeah. Also, really quick, if anybody that's still there could just show their faces just to prove that we were in fact here. I don't know if that's required for the lecture, but cool. Cool. Thank you guys.